Hello everyone, Dr. Suresh here, Professor of Biochemistry. So in this video, we will be talking about disorders related to the sulfur containing amino acids. So we are all aware what are the sulfur containing amino acids present in proteins. There are two sulfur containing amino acids, methionine and cysteine. So here methionine is essential whereas cysteine is non-essential, because if you are having methionine in the diet, cysteine can automatically synthesize it from methionine. So the disorders both are interrelated, whatever like methionine as well as cysteine. So what are the common disorders that you will get because of these sulfur containing amino acids? That is cystinuria 1, cystinosis, homocystinuria and cystathionuria. So these are the four common disorders you will be getting, and we will see one by one. So cystinuria, that is again you can split and pronounce cysteine lysinuria. Why? Because when cysteine is excreting in the urine, the cysteine not alone goes into the urine, it will also pull the lysine, arginine and other basic amino acids. So that is why COAL, coal or cola you can say. So cystinuria is the most common inborn error of amino acid transport. It included in Gerard's tetrad like phenylketonuria, alkaptonuria, cystinuria, right, and tyrosinemia. So autosomal recessive again it is. So albinism, alkaptonuria, cystinuria, pentosuria, or these four are Gerard's tetrad: albinism, alkaptonuria, cystinuria and pentosuria. And the defective reabsorption of what? So here, as these amino acids are important to our body, so they are supposed to be reabsorbed. So the moment the circulation went to the glomerulus, so here the amino acids supposed to be reabsorbed. Because of the defect of some of the membrane transport protein, these amino acids will not be reabsorbed. What are those? Cysteine, ornithine, arginine and lysine. So short form COL, or you can rewrite and remember as COLA, COLA. C stands for cysteine, O stands for ornithine, L stands for lysine, A stands for arginine. So because of the defect of one amino acid reabsorption, other three amino acids will be following cysteine to excrete in the urine. So massive urinary excretion of all these four amino acids, right? And clinical features, if you see, cysteine, because as cysteine is there, so it is least soluble. So know the difference cysteine and cysteine. Cysteine is a single one, cysteine is a combination of two cysteine molecules. So precipitation and formation of renal cysteine or renal caliculi because of the cysteine accumulation. Obstruction or infection, renal insufficient to the urinary tract. A diagnosis: cyanide nitroprusside test. So qualitative test, you can say the presence of cysteine will be identified by nitroprusside test, and which will give positive if there is this one cysteine. Specific aminoaciduria, cystinuria. And treatment: ingestion of large amounts of water, cysteine solubility, alkalinization of urine by giving sodium bicarbonate. So this is the treatment for cystinuria. Now second one, cystinosis. What do you mean by cystinosis? It is a cysteine storage disorder, rare but autosomal recessive lysosomal disorder. It is a rare autosomal recessive lysosomal disorder. The cause is the defective carrier that transports cysteine across the lysosomal membrane from lysosome to the cytosol. Here there is a defect in transport system which carries cysteine from lysosome to cytosol. So clinical features of this cystinosis: cystine crystals accumulation in lysosomes, that means enlarged lysosomes you can make out in liver and kidney, bone marrow, spleen, cornea, lymph nodes, and impairing their function. Generalized aminoaciduria is there. Patients usually die within 10 years due to acute renal failure. And microscopy, if you see cystine crystals in white blood cells. Treatment: adequate fluid intake, alkalinization of urine by sodium bicarbonate, D-penicillamine administration also improves the situation. And if you are coming to talk about homocystinuria, so here homocystinuria, the secretion of homocysteine in the urine. So to understand the homocystinuria, one should aware of the folate trap. So here folate trap is the one. So B12 is one side, B9 is the other side, in B12, B9 one side and sulfur containing amino acids on the other side. So here on the process of making, like methionine will be regenerated. So here homocysteine has to convert back to methionine. Okay. So here when methionine converts to homocysteine, and again homocysteine can convert back to methionine. So here the difference between methionine and homocysteine, okay, there is a methyl group. Methionine and homocysteine, the difference is methyl group. Homocysteine doesn't have methyl group. So when I add methyl group to homocysteine, it can be converted to methionine, and the donor for this methyl group is B12. That too, the coenzyme form of B12, that is methylcobalamin. Methyl. So once this methylcobalamin donates its methyl group to homocysteine, homocysteine converted to methionine, and methylcobalamin converted to normal vitamin B12. Again, this normal B12 will be converted back to methylcobalamin by the donor of methyl group from N5-methyl tetrahydrofolate, that is nothing but B9. So here B9 has got multiple coenzymatic forms. As there is a deficiency of B12, most of the B9 will be trapped as methyl tetrahydrofolate. Okay, because formyl is there, iminoformyl is there, so many other forms are there, but they have different functions. So here most of the B9 is accumulating as methyl form. What happens? B9 deficiency also. So here B12 deficiency leads to the deficiency of B9. Right. So this is a this is like cycle. So first conversion of homocysteine to methionine, methylcobalamin to B12, and again B12 to methylcobalamin by N-methyl tetrahydrofolate. So if there is a deficiency in middleman B12 deficiency, it leads to homocysteine accumulation. So that is the reason B12 deficiency can be assessed by homocystinuria also. Okay, if your urine levels are high of homocysteine, that indicative of B12 deficiency. So here there might be defects for homocystinuria. You can make out, one is cystathionine beta synthase deficiency, because as cystathionine beta synthase is not further processing the homocysteine, homocysteine will be accumulated. That is one probable reason. And the second reason is B9 deficiency, that is N5 N10 methyl tetrahydrofolate reductase, and third one homocysteine methyl transferase. Okay, N5 N10 methyl transferase. Homocysteine methyl transferase, the deficiency of methylcobalamin again. So B12 deficiency, defective intestinal absorption. So there might be conversion of B9 deficiency leads to B12 deficiency, maybe B12 absorption deficiency. So clinical features of homocystinuria: high blood homocysteine levels, you can make out homocysteine and methionine levels, accumulation of homocysteine in the body and it got excreted in the urine as well. So as it is accumulating in the body, it leads to skeletal abnormalities, ectopia lentis, dislocation of the lenses in the eyes, osteoporosis also you can see, mental retardation, thrombosis also prominent features, myocardial infarctions, pulmonary embolism or stroke are the features. And diagnosis: cyanide nitroprusside test, again yes, for cysteine it is positive. Specific aminoaciduria, chromatography plays major role in identification of particular amino acid like cysteine, and estimation of cystathionine synthase activity also by chromatography. Homocysteine levels in plasma normally is 4 to 12 millimoles per liter, but in case of homocystinuria the levels are greater than 100 millimoles per liter. Treatment: pyridoxine B6 may improve the condition which activates the cystathionine synthase, because cystathionine beta synthase is dependent on B6. And complete enzyme deficiency, in that condition the diet restriction such as methionine supposed to be restricted in the diet and it has to be supplemented with the cysteine. Vitamin B12 in vitamin B12 deficiency. So these are the treatment aspects. So if you compare all the disorders of sulfur containing amino acid like cystinuria, homocystinuria, cystathionuria. So deficiency in cystinuria, transport mechanism; homocystinuria because of the enzyme deficiency, cystathionine synthase; and cystathionuria because of the deficiency of the enzyme cystathioninase. And mental retardation you can see in homocystinuria and cystathionuria, because not in cystinuria. Cystinuria is only you can see kidney stones, cystine stones in the urinary tract. And tissue deposition, not all the three. And ectopia lentis you can make out in homocystinuria, thrombosis also in homocystinuria. Renal insufficiency is late in cystinuria but not in homocystinuria and cystathionuria. Renal calculi formation is there, yes, cystinuria, but absent in case of homocystinuria and cystathionuria. Aminoaciduria is there, that which amino acids? Cysteine will be excreted, homocysteine will be excreted in homocystinuria, and cystathionine will be excreted in cystathionuria. Amino acid in the blood absent in cystinuria. Methionine homocysteine levels are high in case of homocystinuria, and cystathionine levels are high in cystinuria. Nitroprusside test is positive for cystinuria as well as homocystinuria, and supplements fluid and alkali take neutralizes the stones. Cysteine and pyridoxine treatment also will improve the homocystinuria, and cysteine ingestion in cystinuria. So restriction, methionine restriction in case of homocystinuria as well as in cystinuria. And the main importance of homocystinuria these days, hyperhomocystinemia and coronary artery disease, because apart from the deficiency or the defects of LDL metabolism, hyperhomocysteine, I mean high levels of homocysteine in the circulation also leads to coronary artery disease. Latest research has proven this. So here lysine, the enzyme by lysyl oxidase forms hydroxylysine, leads to collagen cross linking and maturation. So as homocysteine levels are increased, so this high levels of homocysteine will decrease the activity of lysyl oxidase. So arteries will become fragile and weak. So interaction with lysyl residues of collagen interferes with collagen cross linking, leads to abnormalities of collagen in vessel wall, that especially in cardiac arteries. So homocysteine forms homocysteine thiolactone, a free radical which thiolates LDL particles and aggregates the cardiovascular diseases. These particles tend to aggregate endocytosed by macrophages and leads to foam cell formation, blocking the circulation. It increases the tendency for atherogenesis. So this way homocystinemia is dangerous. Why? Because it is directly related with the CAD, coronary artery disorders. So that's all about disorders related to sulfur containing amino acids. Thanks for watching. Thank you.